afternoon, everyone, and thank you for joining us for another edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue and Transplant Education Program, the Pennsylvania Avenue Baptist Church, and of course, BlackDoctor.org. My name is Suna Halley, and I am your host for today. I'm a program manager at the GW Liver and Pancreas Institute for Quality. And our webinar today is going to be about you, the viewers. We are actually going to be answering questions that viewers have posed in previous webinars. Our panelists today are no strangers of the show. We have Dr. Clive Callender, who is a professor of surgery at Howard University College of Medicine and also the founder of MOTEP. And we also have Dr. Keith Melanson, who is the chief of GW Transplant Institute and professor of surgery at the George Washington University Hospital. Without further delay, let's get into your questions. Our first question today is from Thoretta N, and it says, is it good to take kidney support supplements? Dr. Callender, we'll go ahead and start with you.
Well, I think it's a good question to ask, and I defer to actually Dr. Melanson to answer that question.
Yeah, I think Dr. Callender deferred to me because it's a little bit controversial. So, but the answer is, for the most part, when I've gone in these different health stores and stuff, and so the question would be, at least for me as a physician, is there anything bad that's usually in kidney support supplements? And the answer is no. Now I will tell you that the caveat is, for my patients, remember, I'm a transplant surgeon. So a lot of times after transplantation, we have to be very concerned about anything that will interact with the medicines we give after transplantation. So if you're taking any kind of supplements, including kidney support supplements, we try to tell the patients to stop taking them. But for the most part, the kidney support supplements that most people are taking are fine, and it's really not an issue. However, I will tell you, one of the best kidney support supplements you could take is water. But but yeah, they're fine.
And Dr. Melanson, I actually have a follow-up question to this. Something that we see in our practice a lot is that when patients are coming to their doctor's appointments or for a visit, do you suggest that they actually bring the medication supplements that they're taking, or take a list of it and bring it to the physician? Do you think that's a good idea?
Yeah, great question, Suna. And the answer is absolutely. And a lot of times, and this happened to my own sweet mother, a lot of times people don't consider supplements medicine.
Yeah.
And they should. I mean, not only they should, supplements are medicine. So vitamins, supplements, anything that you take on a regular basis, you should bring it and have your doctor understand what you are taking, because these things will impact your health. They will impact a lot of other medicines, including the new medicines the doctors might want to prescribe. So you should make it a habit to bring your medications whenever you go to your doctor. Let them know what you are taking, because it needs to be in their notes, and it needs to be in your chart. The other thing you need to do, if you take anything that you have a bad reaction to, you should record that and let the team know that. Let the doctors know, hey, I took this one supplement, and this is what was in it, and I had a bad reaction to that. And you want them to put that in your chart. So it is very much a very good practice to bring every medication and every supplement to every doctor's visit.
Thank you so much. We'll move on to the next question. This question comes from Sonia P. How long would you live with dialysis or on dialysis, and can you function with just one good kidney? Who would like to take this one?
It's a good question, and we used to say that patients on dialysis die, 10% of them die every year. And of course, with the more recent changes in dialysis, uh, it may be less than that because we have dialysis patients who are living as long as 20 years. But the ballpark figure is about 10% per year. Uh, and can you function with just one good kidney? Yes, absolutely. That's why some people say I have two kidneys because one is for me to donate to somebody else. So that one kidney is all you need to have a wonderful, long, healthy life. And so those of you who are thinking about being a live donor, it's safe and okay and desirable.
All right. Anything to add, Dr. Melanson, or would you like to move to the next question?
No, I thought that was an excellent point. And Dr. Calendar's right. Just in the last few years, dialysis care has improved with the home dialysis. So people can live longer on home dialysis than they could just going to in-center 3 days a week. But her question is, how long can you live? And that we don't know. I mean, there are always, like Calendar's right, about 10% of people are going to die every year. But you always, and that's why I remember I used to go out to the community and give talks and tell people about the average life expectancy on dialysis. And invariably, somebody in the back of the room would say, I've been on dialysis 30 years.
Oh, yeah.
And the answer is that there are some people, they're usually very, very compliant. They do exactly what their doctor tells them. They don't drink dark sodas. They don't. Oftentimes they're vegetarian. They don't overeat red meat, and those sorts of people can live a long time. I had a patient in my clinic yesterday who's been on dialysis going on 40 years. Right? I mean, that's a long time, and he's still alive. So yes, some people can live an exorbitantly long amount of time, a normal life expectancy on dialysis. But there is no comparison when you look at people that get transplanted versus the people that stay on dialysis. So transplant is a much better option, but the sky is the limit as far as what some patients are able to do.
Thank you so much. Good conversation. And for everyone who's watching, remember, this information is for you, but please take the information back and share with somebody, because you never know who in your community has the exact same question or is looking for the answer that was just posed. So please take this information and make sure you share. Let's move on to our next question from the audience. Are there cases where a doctor will tell you to stop drinking a lot of water? And this came from Gerard, who went to his doctor, and the doctor actually told him to stop drinking water. Does this happen? Is this normal?
Especially if you have kidney disease. If you have end-stage renal disease and you're on dialysis, then in that particular instance, you have a limit of how much water you can take in after you've been dialyzed. And sometimes that limit may be 500 cc's, or it may be even less. But yes, so if your kidneys are not working, if you're on dialysis, and especially if you come to the dialysis unit and you are overloaded with fluid, and having too much water on board can actually kill you. And so therefore the doctor may tell you you're taking in too much fluid, and therefore you need to cut back. Then of course there are instances where some people, instead of drinking the usual 2,000 cc's of water, may drink 3,000, and that may be too much. So there are circumstances, even when you have normal kidneys, where you can drink too much water, and having too much water can be as much a problem as having too little water.
Yeah, Dr. Callan is absolutely right. And there are patients, particularly people that have had strokes or head injuries. You can have these various syndromes where you hold on to too much water. So the doctor will look at your labs and they'll tell you that you need to restrict the amount of water that you need to have. But yes, it does happen that you can drink too much water. And the pumps of the body are the heart and the kidney. And if you overwhelm those pumps in any sort of way, then you're going to hold on to too much water or fluid. And when you hold on too much fluid, that can kill you. So there definitely are times when the doctor will tell you to stop drinking too much water.
All right. And the key word is the doctor will tell you. So
Right.
have a relationship with your doctor, communicate, and they will tell you kind of what to do and what's best in collaboration. So that's what I hear.
You're
Let's
right.
move on to the next question. This question comes from Cassandra. We've been told about two different dialysis procedures. We've been told about two different dialysis procedures. Doctors say the home treatment is the best. Our dietitian says the center is the worst, filled with dextrose. Thoughts on this?
It is clear that the treatment that is associated with the best results is home dialysis, home peritoneal dialysis, because you can have home hemodialysis and home peritoneal dialysis. And the best results are associated with the peritoneal dialysis, home peritoneal dialysis, not only because it's a good treatment, but also because it's a treatment, sorry, that you can take, excuse me, sorry, that you can take over as long as 10 to 11 hours, and you can take it daily. And think about it. Our kidneys function 24 hours a day. When you have hemodialysis, you only get dialyzed, excuse me, sorry, 4 to 6 hours. So it's clear that that's a good effort to try to compensate for what our kidneys do, but it doesn't compare to the completeness of the peritoneal dialysis. And so it's clear home peritoneal dialysis is better than home hemodialysis and is better than in-center dialysis. Keith, what are your thoughts?
Yeah, and I think um, the second part of the statement there, our dietitian talking about all the dextrose, I think what the person is saying is in peritoneal dialysis, oftentimes the dialysate has a lot of sugar in it. So if you're a diabetic, when you're on peritoneal dialysis, your diabetes can be harder to control, which is true, although Dr. Calendar's right. Peritoneal dialysis is the best. And those patients can also gain weight because they're getting so much sugar in being put into their body for dialysis. But long story short, home dialysis is better, and it's better because of what Dr. Callender said. It more accurately does what our kidneys, people that have normal kidney function, do in the sense that you're spending a lot more time doing the dialysis. Even if you're doing home hemo, you're doing hemodialysis longer and slower than they do it in the center, right? And slower is good because you don't have the ups and downs of the blood pressure, so you're less likely to have a heart attack or a stroke. And then longer is good, like more days, because it cleans your blood out better. Same thing with the peritoneal dialysis. Usually, if you're doing peritoneal dialysis, you have a machine in your bedroom, and every night you're hooking up for 8 to 12 hours on that machine. So it's a lot more dialysis. So yes, home dialysis is better. That's why there's been such a push for more home dialysis from the government, from the funding agencies, and now we have more patients receiving home dialysis, and that's been great because I can tell you from being a surgeon, operating on patients that are in renal failure but they're on home dialysis, those patients typically are better surgical candidates than the alternative.
And Dr. Lawson, I have a follow-up question for you regarding home dialysis. What are the restrictions that one person may not be able to receive home dialysis versus going into a center?
Yeah, usually the issue for home dialysis is you just need to be able to go through the education, and you need to, you know, be able to do the things that they're going to teach you to do, right? And you may need help. A lot of patients have needle phobias, right? So they don't like needles at all, let alone having to cannulate themselves. You got to stick some long needles into your arm to be able to do home hemodialysis. But the centers usually will work with you to try to educate you about that. But if you're able to to learn what they teach you, then you can do home dialysis. You also have to have um, a an area in your home that can be isolated and set up in a sterile fashion to be able to do these dialysis routines. For hemodialysis, it usually means a nice little corner where you can sit and receive the treatment, and then your water pressure and cleanliness, all that stuff. But more and more as the technology has advanced, it's made it very much easier to be able to do these procedures at home. You need to have pets away from the area. You got to have you can't have uh, a a place that would be in where the infection risk would be high, right? So you can't be in a damp area where fungus could grow, or it has to be dust free. So the centers are really good at working with people for this, but usually it's the education level of the person, support at home, being able to cannulate themselves and follow sterile techniques. Because nothing is worse than an infection in a dialysis appliance. They can be deadly, either hemodialysis or peritoneal dialysis. I'm sure Dr. Callender can tell you, I've seen it in my career. I've seen patients die horrible deaths from infection, because one of the things that can happen is the heart valves can become infected in people that have dialysis appliances becoming infected, and that's a quick way to die, is a big infection in the heart, because you can get a major stroke.
Thank you for the extra clarification, Dr. Nelson. Let's move on to the next question. This page or this person, Sonia, again says that she has CKD. How do you remove protein out of the kidneys if you are diagnosed with CKD?
Well, I think what that person is referring to is that when you have chronic kidney disease, especially if you're at the level of stage 3A and below, you have protein lost from the kidney. And so the proteinuria, which we use to make the diagnosis of early protein disease, early kidney disease, you are actually losing protein. And so one of the ways that they treat this is to give you medications that decrease the amount of protein that is lost from the kidneys, angiotensin blockers, and especially. And if your kidneys are healthy enough, they can actually use losartan and other kind of medications that not only decrease the blood pressure, which would decrease the damage that causes the protein leak, but they also normalize your blood pressure. And so these things then result in you losing less protein, the glomerular basement membrane and the filtration that normally occurs is allowed to proceed without you losing so much protein. And so it's very therapeutic. And it's important, therefore, if you are found to have proteinuria, that you go to your nephrologist and they begin therapies that normalize your blood pressure and perhaps give you the medications that may decrease the amount of protein that you lose from your kidneys. Dr. Melanson, any other thoughts?
Yeah, I would just reiterate what that last part you just said, Dr. Calendar, because I've seen people that have significant proteinuria, but because of the care of a nephrologist and the medications like the ones you mentioned, the nephrologists have been able to lengthen the life expectancy of the kidneys. So one of the key things that has to happen, if you have protein in your urine, you have CKD, you have to be under the care of a nephrologist. There are primary care physicians and other kind of doctors that can start you on the right track, but you've got to be under the care of a kidney doctor once you get to that point, because this is a life and death thing. And what you want your kidneys to live as long as they can. I've had patients that were in stage 3B, stage 4 for literally years, 5 years, 6 years, 10 years. And that makes a big difference. Although I'm a big exponent, I'm a big cheerleader for a transplant. The longer you can go with your native kidneys, the better. So you definitely have to be under the care of a kidney doctor.
Absolutely. Thank you so much. Sonia, I hope that we are able to answer your question, and I hope that you get connected with a kidney doctor and nephrologist as soon as possible. Thank you. Let's keep it moving to the next question. This one comes from Benita S. How do you clean your liver to prevent fatty liver?
Fatty liver now we recognize is getting ready to become one of the commonest causes of liver disease.
Yeah.
And the first stage of it is that you get diagnosed with having fatty changes in the liver. And the treatment for that it's very important. It occurs very often in people who are overweight. It occurs also in diabetic patients. So to make an early diagnosis of this, I think Asuna and her group are doing liver scans to try to find out if you have a lot of fatty changes in your liver. And in that situation, you need to control your diabetes, you need to lose weight, and you need to recognize that that your diet needs to be changed, so that you don't take in too much fat. And I think those are some of the elemental things that you need to do, because since we've eradicated hepatitis C as a cause of liver failure, fatty liver disease is becoming the commonest source of liver disease and necessitating liver transplantation. Dr. Melanson, any additional thoughts on how do we get people who have fatty liver disease to do the best thing?
Yeah, no, you're absolutely right, Dr. Callender. It had become the number one reason to have a liver transplant. Alcohol is creeping up again after COVID, but usually the problem goes hand in hand. In other words, people that go on to liver failure, they oftentimes have a combination of fatty liver disease, plus they have a toxin like alcohol. But the toxin can be Tylenol as well, or something else. But the point is, you want to get the fat out of your liver. How do you do that? Well, you need to, first of all, stop hurting your liver. Lose weight, like Dr. Callender said. If you can be more active, because being active, even more so than losing weight, changes the way your body releases sugar into the bloodstream. And that's really what has a lot to do with us getting fat just normally, but fatty liver as well. So you want to decrease your weight plus increase your activity. That decreases fatty liver disease. And then you want to decrease toxins. So someone that's been diagnosed with fatty liver disease, you need to stay away from alcohol. You need to be abstaining from alcohol. You need to be very careful. Really, you need to stop using Tylenol because these things can be toxic to the liver. And you need to have follow-up, right? So the good news is it's not static. You can go in the right direction, but you got to start making changes in your life, right? So that's going to be a new diet. That's going to be new exercise. That's going to be getting rid of the toxins and then getting retested. Those are the things you need to do to stop having fatty liver.
Thank you so much. Very practical answers. And I feel like anybody who's listening, again, you can share this information with someone. A lot of times, fatty liver is not something that you will hear a lot about within different talks or on webinars. So this is kind of the first time that I've heard fatty liver being talked about like this and preventative steps. So take this information, talk to your doctor about it, and get ahead of it for sure. Let's move on to the next question. This question came from Gerard, who is the same person who asked about the water. Is it okay to drink cranberry juice?
Cranberry juice is good juice to drink, and it comes up as an issue because if you have bladder stones, kidney stones.
Mhm.
That was often thought about as the best treatment of choice to prevent bladder stones. Uh, I think it may be exaggerated, but it is safe to drink cranberry juice. It's therapeutic, and some doctors have recommended it for the prevention of some kidney stones. As I say, some kidney stones, because the kidney stones are formed by a variety of reasons,
Mhm.
and one of them is associated with cranberry juice helping. Uh, Keith, any other additional thoughts on that?
Yeah, no, I think you pegged it correctly, Dr. Calendar. And the other thing that cranberry juice is always, and I think it's a bit of a myth, is the ability to treat urinary tract infections. Um, but I definitely don't think there's anything bad about drinking some cranberry juice. I mean, juices, they have a lot of sugar, so you always have to be careful in any kind of diet not to overdo it. Like I said, water is better. Drink a lot of water. You want to flush your kidneys. You want to decrease urinary tract infection. Drink more water. You want to decrease kidney stones or bladder stones. Drink more water. So it's something that even I myself, I push myself to drink enough water because it in our modern diets, for whatever reason, there's so many choices out there, from coffee to tea to this. Everybody's like, drink this, drink that. Drink water. The more water you drink, the healthier you are, the better you're going to feel. And take it from me, because I've been making myself drink more water. One of the things that I do, and I'm not sure why, but I drink carbonated water, like
Mhm.
water with bubbles in it. It makes me drink more. So when I go to a restaurant now, I order. I'm trying to become more like Dr. Calendar and not drink alcohol and drink water, 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 water. Well, one of the ways I can drink more water is if it has a little bubbles in it. So I always order sparkling water. That makes me drink more water. The bubbles are good too. So yes, it's okay to drink cranberry juice, but it's better to drink water.
That should be a tagline. It's better to drink water. Just
Right,
drink water.
right.
All right. Thank you. Next question here. This question actually came from a screening that we had Dr. Calendar and Dr. Lonson about an individual whose mother passed away from kidney disease. And unfortunately, that's all the information that he knows. What steps can he take to prevent and educate himself and his family to prevent this from possibly happening?
Well, that's interesting that this is not uncommon. That the only thing you know is that your parent died from kidney disease, and it means that you need to have some investigations begun. One of the things that you think about, especially if the parent died under the age of 50, is whether or not there was polycystic kidney disease, and that can be diagnosed by a number of ways. One is to get an ultrasound of the kidney to see if there are cysts in the kidney, especially if they're over 30 years of age. So, and you can make an earlier diagnosis. You get an ultrasound and you see small cysts, and then if you see large cysts, you know this is a problem. Now, after you do that, there are genetic tests that can be taken to identify whether or not you have a genetic kidney disease with multiple cysts or polycysts. And then, of course, you have that, then we know that those diseases eventually wind up in destroying the kidney. So, getting blood tests to determine whether you have a genetic predilection to any kind of cystic disease, getting an ultrasound to see if you actually have cysts in the kidney are some of the things that you can do. In addition to which, you can also get screened, get your test for urine protein. That's one of the earliest ways to diagnose kidney disease, to see if you're losing protein. So those are some of the many things that you can do to find out whether that your mother died from a disease that you might inherit. Uh, Keith, any additional thoughts on that?
Yeah, no, that was a great point, Dr. Callen, and I totally agree. I mean, now, just in the last 5 years, the genetic testing has just really taken off, and it's a lot cheaper than it used to be. So you can go to your doctor and just give a little bit of blood, and they can test you for every known possible congenital kidney disease. However, common things being common, the most common reason to have kidney disease is, again, high blood pressure, diabetes, obesity, right? Those things are very common. And most kidney disease is preventable because all these three things are treatable, right? So the typical way that people develop kidney disease is they have high blood pressure for years and years and years and years, and it never gets treated correctly. They have diabetes for years and years and years. It just goes from pre-diabetes to metabolic syndrome to diabetes to you get diagnosed, you're undertreated, you start to have problems. So a lot of this stuff is just access to normal, good preventative medicine. So what steps can you do? Access yourself to normal preventative medicine. Make sure your blood pressure is under control. What is under control? The top number should be below 140, 130 even. The bottom number should be below 80. If it's not, and this is the biggest, I go through this all the time. This is the biggest issue I want to get across. If it's not there, it needs to be treated. Right? I don't understand why people walk around going, "Oh my, yeah, it runs a little high. Yeah, it's just a little high." And yeah, I've been told. Well, I don't understand that. That's abnormal, right? You're walking around with a time bomb. If it's abnormal, it needs to be treated. I'm telling you, every day I meet educated people that tell me, yeah, it runs a little high. Like that's okay. No, it's not okay. Right? It's not okay. You need to have it treated. Same thing with the sugar. People say, "Oh yeah, I've been told before." I actually had a discussion with a nurse the other day. With a nurse, the nurse was like, "Yeah, it was just the patient's number was just a little bit above normal, his sugar." I was like, "But he had just had something to eat." I'm like, "No, it should never be above normal. It doesn't matter what you eat. You can sit down and eat a cake. If you are normal, your blood sugar will be normal. If it's not normal, there's a problem." And I think that's one of the biggest issues is people got to understand it's not okay to have your numbers not be normal. It will come back to bite you in the end. So good preventative care is making sure you go into a place where they're not ignoring abnormal stuff in your labs. Because if it's abnormal, it needs to be addressed. So you need to write that down. Again, that's being a good patient. I have protein in my urine. Oh, well, what am I going to do about that, doc? Okay, when are we going to recheck that, doc? Okay, wow. Then you go back the next month. All right, do I still have Oh, wow. Oh, what are we doing about that? Well, I mean, you got to be. It's your body. It's not the doctor's body. It's your body. So you can't ignore that stuff.
Yes. A comment from the audience. You are speaking truth, Dr. Melancon. Thank you for reminding us about the importance of not taking seriously abnormal numbers for our blood pressure. So thank you. That's not normal. And a piece of I wanted to add a comment is that when we go on and do outreach, because we do outreach on behalf of the Ron and Joy Kidney Center and also the GW Transplant, when individuals come and we do their blood pressure, a lot of times the last time that they had their blood pressure read was at the doctor's office. And I think you should be getting blood pressure. You should have a blood pressure cuff at home. You shouldn't be waiting for the next time you go to the doctors to see if it has either gone up or down. That's something that you should be monitoring on a regular basis. Any feedback there?
Yeah, and as a matter of fact, I think that it's more important for you to get your blood pressure taken at home by yourself, because we know that there's white coat hypertension in which you go to the doctor and your blood pressure appears to be abnormal. But I think every person should have a sphygmomanometer, that's the term we use for the blood pressure apparatus, and take their blood pressure once or twice a week. And if the parameters that Dr. Melancon mentioned, if it's higher than that, then you have an issue that can cause you to have chronic kidney disease. And so I think it's really important for you to learn to start taking your blood pressure at home. And if your blood pressure at home is greater than the parameters that Dr. Melancon said, the 40 over 90, then you have a problem that is actually lethal. If not treated, it's lethal. It causes cardiovascular disease, causes stroke, it causes heart disease, it causes kidney disease, and all those things. And so it's uh, one of the most important things you could do for you or your family or your loved one is to get a blood pressure apparatus that allows you to take your blood pressure at home. And if it's abnormal, then to be sure you get treated, because hypertension is lethal. Just as blood sugars are lethal, so is high blood pressure.
Thank you so much. Thank you. Let's move on to the next question. This question comes from Linda C. Why does indigestion affect the kidneys?
My answer would be it doesn't. And I think that one of the things that you need to recognize is that when people talk about indigestion, you know what I think of? Heart attack. Because people who say they have indigestion, the first thing you have to be sure they don't have is that they haven't had a heart attack. Coronary artery disease often pretends to be indigestion, and so if you have difficulty getting food down, don't worry so much about the kidneys. I worry about the heart. And many people who thought they had indigestion actually died at home. Because if you have a problem with indigestion, it's wise not for you to drive to the hospital, but to call the ambulance and have somebody take you, because you could collapse while driving. So when we think of indigestion, we think of more of coronary artery disease and something that could kill you if you don't take the necessary steps immediately.
Yeah, Dr. Callender could not be more correct. And, I've had personal experience with this because my mom, who's a nurse, had a heart attack and thought she had food poisoning. Okay. So this is very much correct what Dr. Callender said. And it is even more correct when you're talking about women. So for women, heart disease normally starts in a different part of the heart than in a man, just because our hearts are made a little bit different, right? A man's heart is a little bit more muscular, which means that the left chamber of the heart pushes more to the left side. And that's why, for years, medical students have learned that the symptoms of a heart attack is crushing left chest pain. But that's not really the way heart disease presents in women. In a woman, the heart is not as muscular. It's turned a little bit in the other way. And the way heart disease can oftentimes show up in a woman, it can be right-sided or it could be more posterior, pushing on the esophagus and the stomach, which is why women think they're having indigestion. And what they're really having is angina, which is, heart disease. So Dr. Callender is 100% correct. If you're having a lot of indigestion, you may not have an indigestion problem at all. You may have a cardiac issue. And cardiac disease goes along with kidney disease because, if you have vascular disease one place, you tend to have it everywhere. But the point is that you should not be thinking this is simply an indigestion thing. If this could be a vascular problem.
Wow, that's such an important message that you're communicating, and also understanding that this could be tied to something else, and the difference between women and men, that the symptom it may present differently in a male versus a female. And even being in healthcare, Dr. Monson, I have to be totally honest, that's not something that's commonly known. You just hear left side, and you hear pain all the time. And, I've been in healthcare now for well over 10 years, and I still hear left side no matter what. There's no designation between women or female. I mean, male or female. That's common knowledge. So thank you so much for that. Before we move on to the next question, I also want you guys to talk about what symptoms of indigestion, what does that look like? So that our viewers can also be cautious of that.
Indigestion is what occurs when you try to belch and try to prevent this feeling in your chest, between your chest and your stomach, that makes you feel that all you have to do is belch and get it out of you. So that it's an it's a feeling of discomfort that occurs around the chest often. As Dr. Melanson pointed out, in women, this may be in the neck, it may be in the chest, it may be in the stomach. And we have cases in which people thought they had a stomach problem. In point of fact, especially in women, it was actually a heart attack. And so that when you have that feeling that there's something in your chest that you just you just can't bring up, and if I belch, it'll be okay, and then you belch and it's not okay, and then that means that what you thought was indigestion is not indigestion, and that there's something else. Keith, you have any other thoughts about?
Yeah, no, you're absolutely right. And the thing about it is, these problems can be intermittent. So one of the things that happens to people that makes them believe that a problem may not be major is that it gets better. But we see this with cardiac disease all the time. Things may intermittently improve, but it doesn't mean you don't have a problem. It's kind of like the canary in the mine shaft. You have the angina or indigestion, and it's as Dr. Callender described. You really feel like you have a big gas bubble that's sitting right below your chest, and if you could just pass it in some sort of way, either belch or from below, that you'd be okay. But again, if this continues to be a problem, you need to get your cardiovascular system checked out. Now, you could really be having indigestion, but again, that needs to be secondary to the cardiovascular thing. First thing the GI doctor is going to do, he's going to check out your heart, because he knows, like we know, that this could be masking something more important. If your heart's okay, then you go through the normal sort of GI workup, which could be different x-rays and even endoscopy, where they go down and look. But that's secondary to what can kill. I'm always telling the medical students, you want to deal with what can kill the patient tonight, then work your way out to, all right, well, maybe we need to do an upper endoscopy. But you want to deal with the most important, the most lethal issue first, then go on to the other stuff.
Awesome. Thank you so much for this information. And the audience, if you have additional questions, please put them in the chat. That's what we're here for. And that's why we designated to do a second webinar focused on your questions, because you guys have very, very good questions. So thank you so much for that. And thank you, Dr. Callender Melanson. We're going to go to the audience again and get some questions that have been posed during this webinar. This particular question comes from Felicia Phillips, and she asks, do you have any recommendations for dialysis patients who consistently experience low energy after dialysis?
I think that's a very good question, because that is common. Many patients who are on dialysis, sometimes for the entire period after dialysis, the entire day after dialysis, they're wasted and they can't do anything else for the rest of the day. And the recommendation is to be sure that you've been studied and you don't have any other additional problems. I have someone I know who just had that kind of experience, and they would turn out to have anemia. And nowadays, when you have dialysis, you get erythropoietin, and so because of that, you shouldn't have anemia. And so, if you have anemia in spite of the fact that you get erythropoietin injections, then that's suggestion that there's something else going on, and you need to be sure that you're not anemic. Number one. Number two, that your blood pressure is not too low, because it's not uncommon, as Dr. Melanson had mentioned earlier, with the peaks and flows of hemodialysis, which is done for a relatively short period of time, that the blood pressure can drop. And that can be alarming, and that can be one of the reasons you have low energy after dialysis. But these are some of the things that come to mind. Keith, do you have any additional thoughts?
Yeah, no, I think you're absolutely right, Dr. Callender. And what I've seen is, like you said about the low blood pressure, usually it has to do with how much fluid they're having to remove when you come in. So the patients that take in less fluid, in other words, your interdialectic weight gain. So when you go Wednesday and then you go back on Friday, what the kidney doctor is trying to do, he's trying to see from Wednesday to Friday, how much weight did you gain? That's why they always weighing you when you go to dialysis. If you're gaining too much weight, then that's telling the doctor that you're drinking too much fluid. So what they do to try to make up for that is they try to pull that extra fluid off by increasing how much the machine is going to pull from you. The more the machine pulls, the more you're going to have problems. So you could have cramping, you could be more tired, like you're saying. So how do you fix that? Well, between dialysis days, you want to not gain a lot of fluid weight. So the more compliant you are with what the doctors are telling you, if you go from Wednesday to Friday and they see, oh, she didn't gain a lot of weight, we don't need to pull that much fluid. Then the machine is cleaning your blood, but it's not pulling away so much fluid. You're going to feel better. And that's why earlier when we were talking about people that survive a long time on dialysis, it's people that don't gain a lot of fluid between their runs. And when the doctors look at their labs are normal, which means that they're eating the right type of diet, not a lot of meat. They're not drinking dark sodas. They're not eating junk food. Now some of this stuff can be socioeconomic, but the point is, the better you're going to do in your diet and your fluid intake, the less they feel they need to do with the machine. And the less fluid they pull off with the machine, the safer it is for you, and the more likely you're not to feel so tired after the procedure.
And also, if you are anemic, in spite of the fact that you're getting erythropoietin, there may be something else that needs to be.
Yeah. Oh, yeah. That's a very good point. Yeah. No, Dr. Callan, and that is missed a lot in dialysis centers. In other words, if you continue to be anemic and you're getting this rocket fuel to push up your blood count, something's wrong. You're losing blood somewhere, and that needs to be worked up. Dr. Callan brings up a good point. You're either losing blood in your GI tract, or it could be cancer. But if you're anemic after what they do to push your blood count up, that's a problem.
Wow. Thank you so much. I lots of information there. And for the audience member that asked a question, thank you so much. Share this information. I'm not sure if you have kidney disease, but this could save somebody's life. So thank you. Let's see if we have additional questions in the audience. This one comes from Tony Escalade. All right now. Is it possible to increase my GFR from 60 to 90?
I think this is a question specifically for Dr. Melancon.
So Tony, first of all, I love the fact that you even asked this question, because most people that are at 60 don't even realize that they could be having an issue. But to go from 60 to 90, you would have to presume that you're younger being younger than, say 45, because it's going to be rare to get your GFR all the way that high as you get older, because it's normal for GFR to go down over time. So, but the answer is yes. And so I would tell you, I would have to probably know more about you, but I would tell you just in general, how you do that. Well, you do that by drinking more water, number one. Number two, you're gonna that's the theme for today.
That's a theme.
Yeah, drink more water. And you want to decrease your intake of red meat, right? Because the more you make your kidneys work, the more creatinine you're gonna have in your urine, the more creatinine you keep in your blood, and that's part of. Oh, okay. He's 40 years old. All right. So you're young, Tony. So yes. So the answer is yes. You can increase your GFR to 90. And what I would tell you is, because I've seen this happen myself, others, including my kids. My boys are all athletes, and they, being athletes, they want to take in a lot of protein. They want to take in a lot of protein shakes. They wanted to take creatine. These things will build muscle, but it can have a deleterious effect on your kidneys. What I tell them is drink more water. Okay, if you need to if you want to take in protein, take that in earlier in the day, not in the evening, right? And then you want lean protein, egg whites, chicken breasts. If you're going to have a steak, New York strip rather than a ribeye. So, and then you want to eat that earlier in the day. At dinner time, you want to be a vegan, vegetarian, or maybe a pescatarian, maybe some fish. But you want your kidneys to work a little less and flush them better. So the better you flush the kidneys, the higher your GFR is going to go. The other thing you want to make sure you're not doing is taking in anything that's toxic to the kidneys. One of the things that people sometimes don't know is that's toxic to the kidneys in high dose is nonsteroidals, ibuprofen, Motrin. These things, if you're taking it too often, and I know some of the gym rats, you go into the gym all the time, you're working out, you have joint pain, and then you take ibuprofen. That's not good, right? If you need to take something, take a Tylenol, but try to avoid that stuff because that can also hurt your kidneys. So the better in shape you are, the more water you take in, the more you exercise, the better the blood flow to the kidneys, the better the kidneys are going to work. The more you decrease the proteins and the junk, preservatives, um, dark sodas, the more you avoid that kind of stuff, the better your kidney will function. But I love the fact that you want to have a GFR of 90. That's good.
Right. But I also want to emphasize, do you have proteinuria? And I think that's important to know, especially at 40. And if you do have proteinuria, then the other advice that Dr. Melanson gave earlier would still apply. That means to get your blood pressure, is your blood pressure normal? Does your blood pressure need to be normalized? And if you're spilling protein, do you need to take some of those medications that are found in those people who have proteinuria? And the other thing to do as well is to get genetic testing to see if maybe you've got a problem. That at the age of 40, if you have a GFR of 90, you want to be sure that they look at the size of your kidneys to see if they're normal. And so these are some of the additional things that you may also want to do as you try to get your GFR to the highest it can be.
And I just want to add, for anyone who does not know what a GFR is, I'm going to read from the National Kidney Foundation. The GFR, your kidneys filter your blood by removing waste and extra water to make urine. So the GFR shows, which stands for glomerular filtration rate, correct me if I said that wrong, shows how well the kidneys are filtering, how well your kidneys are removing the waste and extra water to produce urine. And the higher versus lower rate will determine how better functioning it is. So that's what the GFR rate is that we're referring to.
Yeah,
and
you
also
know, no, go ahead, Dr. Kelly.
Also, one of the things to be concerned about is whether you're obese or whether you're overweight or not. So these are just some of the factors. Go ahead, Keith.
Yeah, no, and he just said that he lost approximately 30 pounds. And I would tell you, Tony, that that's exactly what you need to do more of, because what Dr. Callender is also kind of alluding to is, when you're overweight, you're causing your kidneys to keep up with your size. And one of the things that happens with the kidneys, they have to hyperfiltrate in order to keep up, and that can damage them. And the earliest way to see that is actually protein in the urine. So Dr. Callender is right. You want to make sure you don't have a lot of protein in your urine. But what you're already doing, I saw that you said you're exercising, drinking more water, and losing weight. I would say lose more. I'm trying to get that. Yeah, absolutely. So that's what you want to do, Tony. You want to get rid of that extra weight, and you will find that your body loves that. Your body loves when there's more lean body mass instead of adipose tissue, and that's going to make your kidneys more efficient as well.
Thank you. Thank you so much. Let's see if we have another question from the audience today. All right, this is another question from Felicia Phillips. What are your thoughts about kidney transplants for older patients older than 75 years old? My father was recently dropped from one hospital's waiting list and was not accepted for another. And in both cases, they reference age as a factor.
Age should never be a factor. Comorbidities or other diseases should be a factor, but never should age alone be a factor. And so the question is, why did they do it? So because, and I'd like Dr. Mahanson to weigh in on this as well, because it is clear that it's comorbidities that should be a reason, not age alone.
Of course, Dr. Callender, who's over 75, would feel that way. The and he's right. He is absolutely correct, because I have done patients well into their 80s, and he's correct, because my point is, it's not your chronologic age, it's your physiologic age. Like Dr. Callender, he's over 80 years old. Chronologically, physiologically, he's a lot younger. So I would not have a problem operating on him. But I do know that there are many transplant centers that do have cutoffs, 75 or 70 even. So I would say, if your father is healthy and does not have comorbidities like heart disease, vascular disease, so on and so forth, that he should still be a candidate for transplantation. And you need to sometimes go beyond just one or two transplant centers. It's ironic how different transplant centers can be. I just saw a patient in the clinic yesterday, older, 77, so older than your father, who had been turned down at other programs, and his son, who's 40 years old, was turned down to be a donor, although his only comorbidity was very slight high blood pressure that he now has under total control with one medication. But the center that turned him down, that was against their rules. So for us, it's not an issue at all. So I would tell you, if your father is healthy, you should shop around. Come to my center, or I don't know where you live, but the point is that age alone, as Dr. Callender said, should not rule someone out for transplant. If otherwise, they're fine.
Absolutely. And I just have one follow-up question, Dr. Malanson, in advocating for care when it comes to transplant centers. If somebody is denied for whatever reason, does the patient have the right to advocate for themselves, ask why, and then follow up to see if there's anything that can be improved?
Absolutely. A lot of times, because it can be expensive and heartbreaking and demoralizing for people when they've been told no numerous times. So sometimes when I hear about patients, I will tell the families, look, just send me the record. Just send me the records from the other institution, and I'll look at the records before you come all the way here to see me. And then I'll go through things. But I transplanted a guy, 78 years old, and he had been to a few centers. And what I told him was exactly what I just said. So they sent me all of his records. I looked through everything. And again, I felt like he was a good candidate. I told him, I don't believe that we would say no to you. Mm-hmm. Come and go finish the evaluation. So he came, finished the evaluation. We said yes. We did the transplant. He's doing fine. So yes, you are absolutely right. Patients have to be advocates, and what they have to understand is, again, there's such differences in these centers, even in geography. The way we are here in the Mid-Atlantic and the Northeast, I think is a lot more aggressive than in other areas of the country. So don't give up unless they have an obvious reason. If they say, well, your heart is, you have compromised cardiac function, and that's so obvious, well then, yeah, that's a good reason. But age alone, like Dr. Callender said, age alone should not be the reason.
Thank you, Dr. Malton. I believe that may be one of the last questions. Let's see if we have one more. If not, I just wanted to also let everyone know that as a part of the Ron and Joy Paul Kidney Center, we do free screenings where we do and we check to see if there is any protein in your urine. And we have screenings at least 1 to 2 times a month. So if you're looking to get screened for free, you can do so by calling 1-833-KIDNEY3. And then that can be a screening that is provided to you if you're in the DC metropolitan area. Okay. I don't believe we have any more questions. Dr. Calendar, any final words or advice to partake on our audience?
Well, I think this has been an opportunity to discuss so many things that people wouldn't otherwise hear. And I think the advice is clear. Having a healthy lifestyle, exercising, we've left out meditation, which I think is an important addition to all of the other things. But his emphasis on eating less red meat and more vegetables and fruits cannot be overemphasized. Thanks for letting me participate in this meeting.
It's always an honor, Dr. Calendar. Dr. Melancon, any parting words?
Yeah, again, I would just emphasize what Dr. Calendar said, and he's right about meditation. Numerous studies have showed people that pray, that meditate, have lower blood pressure, are just healthier in general. And to that, I would add, I read a study just the other day, and it was a very simple thing. It was people that eat more meals at home. And then not only did they talk about eating more meals at home, but then they went and for a matter of fact, I tried to show that to my wife. She didn't want to look at it. But I was trying to, the other thing they did was they showed like how much salt and how much salt is used in a typical home dish. Even people that think they're using a lot of salt when they cook, it pales in comparison to what they're using in the restaurants, right? Particularly your faster food restaurants, right? So the point is, if you just cook at home, if you just dedicate yourself to eating at home a certain amount of days out of the week, you're getting healthier because the food is going to be healthier no matter who's cooking it. So that's what I would encourage people to cook at home, cook. And also, this is what I want to emphasize. Not only cook at home, but what is cooking? Because sometimes people think reheating prepackaged stuff is cooking. Now, I'm from Louisiana, Suna, right? And that just hurts me to my heart. Getting a package of something and reheating it, that ain't cooking.
Is that not cooking, Dr. Melancon?
That's not cooking. Okay. When you have to chop up stuff, and put it in a pot and work with it, that's cooking. So I just wanted to leave on that note. I people need to eat more food at home, and I hope this is taped and my wife gets to see it because she always wants to go to the restaurants, always. But anyway, that's
I think
my Friday message.
You're changing a lot of narratives here because a lot of opening the bag and putting it in the pot when you hear it sizzle. I thought that was the part that means you're cooking. But okay, Dr. Melancon, you got to cut it up.
Yeah.
And then also the tagline of the day: drink more water. Drink more water, everybody.
Drink more water.
So we'll end on that note. Thank you so much for tuning in today for Kidney Talks. We will be back in 2 weeks. So please make sure to join us on May 12th. Again, thank you so much to the Ron and Joy Paul Kidney Center, to MOTEP, the Minority Tissue and Transplant Education Program, Pennsylvania Avenue Baptist Church, and of course, BlackDoctor.org. My name is Suna, and have a wonderful weekend.
Thank you.